Okay, sorry everyone for the late start. We had some technical difficulties on my part, but good morning. Thanks for joining us for the OHCA webinar on the state testing rule. My name is Catherine Van. I'm the communications coordinator for the Oregon Healthcare Association. Just a few announcements before we begin. We're going to have about a 30-minute presentation from DHS, and then we'll kick it off to the Q&A portion. We recommend that you watch this meeting in speaker view. That way you always see who's presenting. All attendees have been muted just to avoid any background noise, but we encourage you to submit questions via the chat feature at the bottom of your screen. I'll do my best to monitor them and do my best to get to all of them during the Q&A portion. We've also received your questions that you've emailed ahead of this webinar, so thank you for that. As always, thank you for your patience if we experience any more technical difficulties. So let's get this started with your presenters, Mike McCormick and Rachel Incurrence. Welcome.
Thank you, Catherine. Good morning, everybody. For those of you who don't know me, I'm Mike McCormick, and I'm the Interim Director for the Aging and People with Disabilities Program within the Oregon Department of Human Services. And I appreciate all of you being here today. So today we're going to give a good overview of the testing rule. Hopefully we're going to be able to answer all of the questions that you have. The questions we're not able to answer, we're going to be taking notes of those, and we'll follow up and incorporate those into our frequently asked questions list. And you can see the overview that we're going to do today. So one thing you'll notice here is that I am not going to be addressing indoor visitation policy. I understand that that's a really hot topic right now. There's lots of questions and concerns around that. I get it. We are currently working on communication materials that have the objective of simplifying the admittedly pretty complex policy that we issued a week ago on indoor visitation. We hope to publish some communication materials on that on Monday. We will also be assessing all of the feedback that we're getting and determining whether we need to do a webinar with all of our providers on that. So stay tuned, but please, we ask for your patience. That is not the objective of today's webinar. So let's move on. I think that all of you are aware that in March, we adopted a strategy that it resulted in the issuance of executive orders when facilities have suspected or confirmed cases of COVID-19 amongst either residents or staff members. Here are some key statistics since we began this. We have issued 669 executive orders in assisted living facilities and residential care facilities. 558 facilities received them. So the difference between those numbers, obviously some facilities receive multiple executive orders. So 66% of facilities have received one to date. Nursing facilities, 689 executive orders with 129 receiving it, 98%. I think there's only one, maybe two that haven't received an executive order to date. Hopefully you can see here, there's no stigma associated with executive orders. This has been a deliberate strategy that's tried to help facilities control COVID in their buildings. I know that some of you are frustrated with the process, but we believe that overall it has helped the residents as well as the facilities in managing COVID outbreaks in their facilities. So continue that reporting, and we appreciate everyone's cooperation to date. Next slide. So today we're going to be talking about a new rule requiring monthly staff testing of all staff members in long-term care facilities. So why are we doing this? Well, I don't have to tell you, staff are the ones who are almost always bringing the virus into facilities. So some key statistics, fewer than 13% of COVID-19 cases are associated with congregate living settings, but the deaths, 57% are attributable to long-term care facilities. So the philosophy is that the routine testing can reduce both the likelihood and the severity of the outbreaks in the long-term care facilities. So I would be remiss if I didn't take this opportunity to give you a quick pep talk on managing COVID in all of your buildings. So I can say, I think as of today, we're exactly 8 months into kind of like when we mobilized all of our efforts. And I can tell you that most of you really have this down now and you're able to manage the outbreaks effectively, and we couldn't be more grateful for your efforts. However, there's still a handful of you that are caught flat-footed when COVID enters your building, and that is just simply not acceptable heading into month 9. So I need to remind everybody that you need to have a plan for when COVID enters your building. So first of all, you need to assume, even if you're a COVID-free building, you need to assume that someone has it. There has to be appropriate use of PPE at all times. If it's used appropriately at all times, the risk of transmission is practically nothing. You need to have a plan for how you're going to deal with staffing shortages. As I've said previously, we've seen it over and over and over. When COVID enters a building, you're going to have a certain percentage of your staff who are going to either be unable to work or unwilling to work. It might be 10%, it might be 25%, it might be 50%. We've seen 100% turnover in buildings, and buildings not being prepared. Well, that's no longer acceptable. You need to be prepared now. That means you need to potentially overstaff. You need to have multiple contracts with staffing agencies. Maybe you need to pursue cooperative staffing agreements with your brother and sister facilities. All of that around, you need to have a plan for cohorting staff, so that certain staff are only serving individuals that are COVID positive. You need to have a place for isolation, etc. But that's not the objective of today, but I couldn't resist using this opportunity to drive home that message again. So today's presentation, I am pleased to hand it off to Rachel Currens-Henry. She is a member of the executive leadership team within our COVID response and recovery unit. And this is a new organization which facilitates and does cooperative work between a multitude of agencies. And she's been a valued partner on this effort. So I'm going to hand it off to Rachel. Thank you.
Thanks, Mike. I appreciate that. And thanks so much for setting the stage for today. First, I want to thank OCA for presenting and for facilitating this forum. It's very helpful to ensure we have a direct audience, to ensure that questions are asked directly with the providers who have been doing so much work to ensure that residents and staff and facilities stay safe. As you know, Oregon's long-term care facility testing plan was initiated and directed by the governor back in June. And as part of that, all of you have worked over the last 4 months to ensure that we had 100% compliance and testing of residents and staff. And I can't thank you enough for your efforts. I know it has been a hard effort, and our hope is that that has been the pilot and the testing ground, if you will, to prepare us for moving into phase 2 of the testing rule, which is that routine testing of staff. And that is what we're here today to talk about. Now, part of why we're here as well is because the original plan that we had in June had those 2 objectives, as you can see here, noted on the screen, and which we had presented, and which you're all familiar with. But since that time, CMS issued additional guidance in September requiring all nursing facilities in the United States test staff at least once a month, and in sometimes once or twice a week. Additionally, since that time, the federal HHS also issued antigen testing devices to all Oregon nursing facilities. So with that additional federal guidance coming out, we're here today because we need to explain that we needed to update phase 2 of the governor's long-term care testing plan to make sure that we aligned with the federal requirements. Our objective is to ensure that we don't have multiple testing streams. What we didn't want to have is have requirements at the federal level and also have additional details and a whole separate testing plan at the state level. So as you can see here, this slide has links to all of the materials. And I'm not going to go through all of these today, but we want to make sure that you have these as a resource. And we're going to go through some certain sections today that we think are important to highlight, in particular, where the differences are for how you can prepare to conduct routine staff testing. So as you see on this slide, this slide shows the sections in the Chapter 411 Division 60 temporary rules sections that were updated. At the beginning of this presentation, we're going to start by going through highlights in the definition section and in the routine staff testing requirements. Later in the presentation, we're going to go through the other sections noted, the admissions and readmissions, trauma-informed and culturally responsive testing, etc. And we'll identify the changes that were made there. But again, I want to identify that the focus where we think we need the most training and explanation and work is to highlight the routine staff testing. And that is our objective today. So we're going to start with the definition of associated staff. So I'm not going to read the screen. You can see this, but I want to make sure that I'm connecting and explaining the story, if you will. So back in June, when the governor issued the first draft rule, and the rule that came out, the temporary rule that had a definition of associated staff. Initially, we had a broad definition of associated staff that somewhat mirrors this definition, but very quickly, to ease administration, in mid-June, we narrowed the definition. So the June to September baseline testing requirements required that testing for staff. The definition was that associated staff meant individuals providing direct care services via a contractual relationship with the facility, period. That was it. So what you can see has changed is that more people entering nursing facilities, assisted living facilities, and residential care facilities will be tested, and that facilities are responsible for ensuring that associated staff obtain that testing. The language that we included in this rule was intended to mirror the federal definition. And I'm going to note, because I'm sure that there are questions, I'm going to go through the high-level sections of the rule, and then I'm going to share some interpretive guidance, because we understand that the question about who should I test and who meets the associated staff definition is one that you may have. So thank you very much for being here today and guiding and working with us through this. So the context as well. You can see here, 411-60-27. We included the high-level requirements here, and in terms of our messaging, as you can see, we want to make sure that we were aligning with the CMS guidelines where possible. And so that's why in the rule, you're not going to see a high degree of specificity about what that means. And so we need to make sure that today and in other trainings and in other questions and FAQs that we may have and materials on our website, we're helping to flesh out the rule. If the rule is our framework and our scaffolding, if you will, we need to help make sure that we fill in the rest and work with you in partnership. I'm going to highlight here on page 2, on number 2, what I want to highlight is that we recognize that meeting the testing requirements may be a challenge, and I do want to highlight here that there's a clause that says the facility may request an exception and an alternate testing schedule from the department. We did include that language in the rule. I want to acknowledge that obviously it is our intent that we want to ensure that all facilities are able to comply with the monthly testing requirements and potentially weekly if you are in those higher county positivity rates. But we did put provisions in the rule for you to connect. We'll make sure that we have information on the DHS website that will have an email link for facilities to contact if they do have questions or need to request this type of exception. On the next slide here, just highlighting the final provisions in this section. you can see that we are requesting that facility staff and associated staff testing that we have documentation. Later in the presentation, we're going to provide some additional clarification about what would be acceptable in terms of not actually gathering individual test results, but having an attestation, and we will clarify that in the guidance. So we hope that that will be helpful to ensure ease of administration of this rule. But I want, again, to here, we're showing what the actual rule language is. Slide number 6. Ensuring that we have, each facility has procedures to ensure that you are, that facility staff who refuse testing or are unable to get tested is in place. I want to acknowledge this language has not changed from the June rule, so hopefully you all will have these procedures in place already, and that is the expectation. This language continues to be in the rule language. So I just highlighted the definitions and the rule language itself. Now, part of the question that we've been receiving is, what does this actually mean in terms of who meets that associated staff definition? And I know there's a request potentially to say, is there a chart that we could just say, check the box, yes, I am this type of person, and should I receive a test? And part of the challenge is that there is a nuance here, and I want to identify the intention. What we're trying to give here is thinking about criteria. If there are individuals or caregivers who provide care to service on behalf of a facility, how would you determine whether they should get a test? Because maybe we've heard questions, maybe somebody's on vacation, maybe a person only comes to the facility once a month or once every few months, and they don't have a contract. Do they count? So part of what we've put together, and we're open to feedback, because this is, again, guidance that we're giving in a presentation today that we will be putting into a document and having on the website. But we're looking at the following criteria. So if an individual with whom the facility has a contracted relationship, that's one set of the criteria. If an individual also has close and prolonged contact with the resident for more than 15 minutes within 6 feet, and an individual meets both of those criteria, well, then that would signal, yes, they probably do need a test. And additionally, we want to identify if there are individuals who provide services to many residents in multiple buildings and facilities, absolutely, those are individuals who we want to be tested. Or, as you can see here, individuals who enter facilities more than once a week. So what we've attempted to do, and I want to acknowledge this is a process and a journey, and we are open to feedback, is to help identify criteria for you to use in interpreting that associated staff definition and identifying who will need a test. I imagine you may have questions in the chat function later on today, and we welcome additional discussions and feedback here. At this time, I'm going to continue on with some of the guidance, and then we'll open it up to questions. In terms of frequency, the routine testing of staff will be more frequent than once a month. We do have a link to the CMS guidelines, and below you see the chart that shows the CMS categories in terms of county positivity rate in the past week, and then the aligning minimum testing frequency. Facilities must choose to follow either the CMS or the OHA positivity rates using one of the resources. Now, it's really important, facilities need to be consistent. So you can't pick and choose week to week. This week I'm going to follow the CMS positivity rate. This week I'm going to follow the OHA. Facilities need to choose and pick a rate and stick with it. Now, I know there's a question, we're following the federal guidance here, where the federal guidance to nursing facilities was to allow facilities to have flexibility and to choose whether they wanted to have the CMS or the OHA guidance. We do have links here. If there are questions on this or there's clarity, we're open to discussions. But this would be what would be documented and through SOQ. Also identifying in the CMS guidance on the testing frequency, you have to stick with the positivity rate in a tier for the same consecutive 2 weeks. So I think this is an important nuance to make sure that facilities understand, and we're happy to answer questions on this. We have some of our experts who have been working on the CMS guidance with nursing facilities on the call today who can help explain this or answer any further details. A few additional points. Related to the rule requirement of having documentation of testing, we will allow facilities to have a policy to accept attestation as verification of completed testing. We hope this will be helpful, but it is an expectation that if a surveyor comes in and asks you, you would need to be able to produce the documentation. We also need to ensure that testing results from other facilities are accepted. We don't want to have duplicate testing. We don't want to have, we need to be streamlined and working together, and we hope that you would accept those results. If a home health agency, for example, a home health care provider had a test just the following week at another facility, and the facility was in the monthly testing, that should count, and you should have an attestation that that testing would count. And then the fifth item, we put this in place because to clarify that facilities are no longer required to submit a plan to the state for testing. The expectation is that you will do the testing and that you will secure those contracts. And the reason why this statement is here is because the June testing plan that was on the website noted that facilities must have a plan and submit a plan for testing. We're essentially saying you don't need to submit the plan, you just need to do the testing and follow the rule guidance, the rule and the guidance, excuse me. There's no changes to reporting. This is just to continue to remind facilities of the importance of reporting test results. And number 7, we want to ensure that we're setting a standard that we want to ensure that facilities don't mandate a higher standard for staff testing than the state policy, and we establish some criteria. Unless the facility will determine that they'll pay for the test, the facility and the contracted staff agree to it, and it doesn't limit resident access to needed services and supports. So at this time, I just want to pause before I go into this next section. I imagine there will be questions, and we're absolutely open to continuing to talk through those questions later. This is a start of additional guidance for you as we understand how to interpret the monthly testing results. As we pivot to this next section, part of where we know that many of you have received these point of care antigen tests, and there are many questions with regards to how to use these tests. Today's presentation doesn't focus on the clinical guidance for antigen tests, but I want to highlight that we do have provisional guidance on use of antigen tests available, and we are updating that guidance. So in future meetings or discussions, we're happy to go through that additional clinical guidance where we have our clinical leaders on the line. But for today, we want to just make sure that we acknowledge that these testing devices are here and that the intention is to ensure that they're meeting the testing needs and they are a resource that is used and available. Want to acknowledge as well that one of the major questions that we know we're going to get is understanding the financing. So just acknowledging that our facilities should have direct contracts with private testing vendors, and they can choose to work with those testing vendors for testing. We do have a list of resources available that we are absolutely willing to share with all of our facilities. I also want to acknowledge that if any facility that did not receive a point of care antigen test from HHS who would need assistance in obtaining a CLIA waiver and getting access to antigen devices if you would like to have those. That is an available option to you, and you can contact the crew testing branch. I also want to highlight a memo that we have issued with our OHA Health Systems Division partners that will go out to hospice and home health agencies. This memo identifies that hospice and home health agencies are in scope for needing testing. It does identify that hospice and home health agencies are expected to help secure and do some of that testing and work in partnership with nursing facilities and assisted living facilities and residential care facilities. So I would ask and direct your attention to that memo as an additional tool to help understand how we're trying to ensure expectations across different parties for getting testing. There's a role that we want to ensure hospice and home health agencies play as well in this financing. That concludes the sections of the definitions and routine staff testing. We're going to briefly go through the 5 different sections that were also in the rule and identify what changed. And then before we go to questions. In the admissions and readmissions testing section, the language was updated to ensure that we align with clinical guidance. Again, this is not a clinical focused call. We're happy to have additional discussions. And I know that we do have trainings that we have planned with our clinical leaders at OHA for future trainings, where we will continue to talk about the OHA clinical guidance. So stay tuned for more information. We did pare down some of the provisions about trauma-informed and culturally responsive testing. However, we do want to ensure that the provisions continue to ensure that we maintain a commitment to health equity and trauma-informed practices. As a reminder, we do have training videos available that we have posted on the website, and we do have a separate training video for informed consent that is under development. There were no changes to the consent section of the rule. In terms of outbreak prevention, this language continues to be in the rule. We did clarify that the 72-hour requirement was specific to the specimen collection activity itself, as opposed to ensuring overall testing, knowing that many times lab results will come after the specimen collection. We wanted to clarify the expectation was that the specimen collection be completed within that time frame. Finally, the reporting section included a cross-reference to CLIA requirements and REAL-D reporting requirements to ensure that we were identifying where facilities would be responsible for reporting race, ethnicity, language, and disability data to comply with the state statute. That concludes the section on additional provisions in the rule. Next, I'm going to identify just 2 FAQs or 3 FAQs that we've received, and then we're going to go to moderated questions. So as you can see here, the first question is about guidance on retesting staff. You'll see here that staff who had been previously tested do not have to be retested within 90 days as long as they don't develop new symptoms of COVID. And again, this is if you had been a COVID positive test. So this is a very important clinical nuance that will help to ensure that you can reduce some of that routine testing if a person had been COVID positive. And we're happy to answer questions there. In terms of arranging for testing, we have questions on insurance coverage. We acknowledge that as we move into routine testing, this is definitely an area where insurance coverage may not cover testing if an individual does not have symptoms. Just acknowledging that the expectation in this rule is that staff will need to get tested regardless of whether the test is covered. And this is where, again, we have use of the antigen test, and I know we are encouraging all of you to have contracts with testing vendors to help complete the requirements. And then finally, I'm not going to read through this, but I do think it's important to ensure that the test results, how they're going to be used, and privacy protections. We do have information clarifying that privacy and protected health information is, of course, of utmost importance, and confidential positive results are shared with local public health authority for contact tracing purposes. And you can read through this answer in detail. So with that, I do want to make sure that we move to our moderated questions so we have sufficient time to answer them. I will ensure that we have some of our panelists as well available to help answer some of these detailed questions. So with that, Catherine, I'm going to turn the floor to you to help us with the moderating here.
Okay, we do have a few questions. So this is regarding the CMS updates. What time and day does the CMS update the county positivity rate spreadsheet? This past Monday, it changed midday. It caused some confusion.
All right, I'm going to ask Stephen White or Dave Alm. Do you have that information by chance?
Hi, everybody. This is Dave Alm. We've been on regular conference calls with CMS nationally, and we have not had them tell us a specific day or time that that's updated. But their direction is essentially pick a time or a day every 2 weeks and stick with that date and time and use what you pull at that time. So you shouldn't need to go back in and check multiple times a day or multiple times a week. Just pick a time, pick a day, and do that every single time, and you'll be fine.
Okay. And another question, we just got news that NHSN will require us to report testing there. Will the state accept this as reporting, or do we have to report both on the OHA website and NHSN when we run POC testing?
Hi, this is Rachel. I'm happy to field that one. You are correct that we've been monitoring that NHSN is also going to be requiring that reporting. At this time, it does look like we will have duplicate reporting that is needed. We are taking this back to the OHA reporting team. We have a team that's looking at this to see if there's any streamlining we can do. But there's nothing we can do about the requirement to report to NHSN. We're going to see if there's anything we can do on our end, but I'm not necessarily optimistic that we will have an answer or are able to make changes. Right now, it does look like we are going to need to do both sets of reporting. I also want to acknowledge that in the nursing home point of care antigen testing provisional guidance, there is a reporting section, and the guidance that I mentioned that is being updated for the antigen test use will also have the updates to clarify the NHSN reporting requirements, so you have the reporting requirements all in one place.
Okay, and do we have an update on securing more funding for testing reimbursement?
Yes, so we have been, we received $2.5 million to reimburse facilities for staff testing that wasn't associated with the baseline testing. And hopefully you've been receiving those reimbursements timely. I think our staff have been processing those on a daily basis. Unfortunately, the funding ran out earlier this week. And so all of the requests for reimbursement were processed in the order they were received. And yesterday, I received notification from the governor's office that there is governor's office support and presiding officer support at the legislature for allocating more funding for testing. That's a good sign. That's not a guarantee that we're going to get more funding to reimburse providers, but it's definitely a good sign. I think there's probably going to be an emergency board in the very near future. I'm hearing rumors that it might be a week from today. So hopefully more funding will be allocated. And if it is, we will immediately resume reimbursing facilities for all of the staff testing that is occurring. So stay tuned on that. I'm cautiously optimistic.
What is the deadline for reporting results to RealD, if I have that correctly? REALD.
Thanks. I'm going to see Stephen White. Are you able to answer that question?
Hi, yes, can you hear me?
Yes.
You know, there's no specific deadline for reporting that. You know, that information needs to be gathered and reported whenever you do testing. I think there's going to be some need for additional clarification around this. You know, again, as Rachel mentioned, this requirement is part of some separate legislative action that requires state agencies to report on RealD in different particular scenarios. And so with some legislation that was passed in the most recent session, there was some specific requirements around reporting RealD data for all sort of COVID-related interactions. And so, you know, when you do testing and when you're reporting lab results, either you or your contracted laboratory will need to enter that data. I think the question is, you know, the legislation only requires that that information to be gathered once a year for a person. So it's not going to need to be reported each time you test the same person over and over again. So I think it'll just be a matter of making sure that we clarify that and have our system set up so that we gather it once and they don't have to keep going back. So the intent is to make sure that that data is gathered and reported when test results are being reported. But that also, you don't need to keep doing that over and over again for the same person.
Who do we report point of contact testing to? Also info about race, ethnicity, etc.
Catherine, I think, hi, this is Rachel. I think that's related to what Stephen was just noting. So I'm just going to connect a few dots. This also relates to the previous question we had about NHSN reporting. So one of the clear differences and reasons why OHA is collecting data is because OHA is collecting information on RealD, while NHSN does not. And that's an example of the differences of the type of data that we get. I can't speak definitively if that's all of the differences, but that's an example. So that reporting section in terms of how to report to OHA and is found in the nursing home point of care guidance. And I can see if I can pull up that document as well while we're taking questions.
Thank you for the clarification. What has your communication been with temporary staffing agencies surrounding testing? Are you expecting them to arrange testing for their staff or each facility is going to do the testing? Often these staff work only one shift a facility.
This is Rachel. I'm just going to note in terms of the expectation is that facilities are responsible for ensuring all of those staffing agencies that are in the definition. It's the facility's responsibility to ensure that they've been tested. So that can be, those are discussions that we encourage you to have with contracted facilities to determine how a facility will navigate that. And I would open it up to any of my other fellow panelists if you have any other thoughts to offer.
I concur. I interpret this as a contractual matter that needs to be negotiated between the facility and the staffing agency, but the staffing agencies are definitely subject to the monthly testing requirement. Thank you.
Okay. And based on CDC guidance indicating antigen testing is less reliable than PCR in asymptomatic people, if a facility chooses to use antigen testing for routine staff testing, can they follow up with PCR to confirm the positive result?
Hi, this is Rachel. I'm going to acknowledge it sure seems, I know we have a lot of, those are great questions. And That will be updated in our clinical guidance that is coming out as well. And so the anticipation is that we will be identifying if there was a positive antigen test and the person was asymptomatic, then we would ask for a follow-up PCR for confirmatory. That was a discussion that I know we've had with some of our clinicians at one point. We are planning, that was brought to the governor's medical advisory panel, and that will be put forth in OHA clinical guidance. I don't believe it's posted yet, and when it is posted, we will gladly share that. And we are absolutely open to continued discussions with our clinical leaders and CMOs and facilities to help explain that further.
And this question is regarding associated staff. Those who come to our facility, like PTs, OTs, and home health, do we test them, or do they give us the results of their tests? And how often do they need to give the test results to us?
So this is Rachel. Jack, would you like to field that? I think you just went off mute.
Yeah, I was just going to step in quickly there and say, yeah, those organizations do fit the criteria, the definitions for associated staff, and do need to meet the testing criteria, just like the rest of staff. Now, that can be done through your contracts with those agencies. If those companies are performing testing, it would need to be done at the same rate or the same frequency that your facility falls under, according to your county or local positivity rates. So I think I addressed everything there. So the facility would be responsible for ensuring that those employees are tested.
Are home health providers allowed to refuse provider services due to not wanting to be tested?
Jack, do you want to field that one as well?
Are home health providers able to refuse to provide the service? Is
yes,
that the question? If somebody, so in order to be working in the facilities, we do need staff that are in direct, close proximity to residents to be tested. If the facility is contracting with home health agencies that aren't performing testing, the facility really needs to provide to ensure that care is provided and is available for their residents. And that really is the key. So they would need to work on that contractually between the agency and the facilities.
And how do we financially support the testing? 90% of our staff are young and don't have insurance.
Yeah, so again, our hope is that the legislature is going to appropriate more funding for reimbursement of testing. But stay tuned. Hopefully we'll have information on that next week or the week after.
How do assisted
Make sure
living?
that you're keeping the records, however, and Kelly asked a good question. So if you've submitted a request for reimbursement now and it's been denied due to lack of funding, that's going to be the first one that we're going to pick up if we are appropriated new funding. So it's always going to be processed in the order received. So make sure that you maintain all of your documentation, and hopefully we'll get an additional appropriation.
And how do assisted living facilities obtain any antigen testing machines and supplies?
I would direct you to the presentation where we have the email address to request those services.
And we can send the presentation out to attendees later today. Let's see. If a facility is on weekly testing and a staff member is on vacation for a week, what is the expectation surrounding testing?
Hi, Catherine.
Hi,
oh, good. Jack, please jump in.
Yeah. And Rachel, you may have something to add to my answer, but my response would be if you're on weekly testing and you've got a staff member who's out for a week or 2 weeks, that person would just need to be tested before coming back to work. So they don't have to be tested when they're out on vacation or out of the state or wherever they may be, but they would need to be tested before coming back and then fall into the regular frequency for testing once they return to work.
And following up with that question, if an employee works once a week and the facility is on twice per week testing, is that employee still expected to be tested twice a week by the facility? And how should testing be handled for on-call staff who only work a shift once in a while?
You know, I'm going to answer that one by saying that you know, regardless of a person's scheduling, all of your employees need to be tested according to the frequency that you're under. But that may be something we'll flesh out a little bit and provide some more detailed information in the FAQ that we hope to be sending out soon, unless some of my colleagues have a different idea about that. I'm not quite sure.
Jack, I think that's a good call. And you know, part of it, just a reminder, the intention is preventing COVID from entering the facilities. So there's going to be circumstances when if someone's on vacation, they're not there. But at the end of the day, if you're still part of a monthly testing requirement, the expectation is that that person, if they're working sometime in that month, has to be tested. So I think those are some of those nuances that we really are hoping that that interpretation that we gave earlier in the slides to think about how should I be thinking about of who needs to be tested could be a framing as well for you to consider.
Going back to the question about financing, was the $2.5 million available for serial testing or just baseline testing?
That was serial testing only. The baseline testing did not have a limit associated with it. So any requests for reimbursement for baseline testing that have not been submitted, please get those in as quickly as possible.
A question about PPE. Who are the best contacts for getting more PPE, since we only do testing, weekly testing. We only do weekly testing for PT, OT, and any home health.
So the question was on PPE.
Yeah,
I believe the best contact for obtaining PPE still is your local public health office.
All right, just scanning some questions here.
Catherine, can we clarify that there's a question about 25% weekly staffing, and I just wanted to flag that because that's a question that is posed, I believe, because in the June testing plan we had that document had a provision that said expectation for ongoing testing would be like 25% a week, and that's what was suggested for the ongoing testing. I want to make sure we clarify, we didn't speak to that because that is no longer included in the testing frequency plan for routine testing. The expectation for the testing is what you saw presented today and what is in the rule, that you would follow the CMS guidelines, which shifted away to the potential weekly, twice weekly, or monthly. So that is why we moved away from that language.
Thank you, Rachel. Okay, our screeners are screening people like hospice. They ask for proof and write down date of test and result. Typically, the person being screened has a picture on their phone. Would this written documentation be acceptable?
Jack or Lynette, I believe that would be from what the SOQ surveyors would hold. We're saying yes, I believe that would be acceptable, but I want to verify from your team if is indeed the answer you want to give.
Yeah, that is correct. And the bottom line is the facility needs to receive reasonable assurance that the testing has happened, and whatever format that proof may be, just use reasonable thinking to ensure that it does indeed indicate the tests were completed and were negative. But we're not going to require a specific form or a specific format for those results. but facilities will need to, if asked, be able to provide documentation and show that they are ensuring that testing has happened for those individuals coming into the building.
Okay. We have a follow-up question to the resident testing requirement. If an employee tests positive, then all residents are to be tested within 72 hours. Is there a resident that tested positive? If there is a resident that tested positive, then how often are the residents tested after that?
So that, I believe, is referring to the outbreak testing. And that is where if somebody tests positive, then within 72 hours, you need to have implemented testing of everyone within that exposure range. So every residents and staff within the building. Current CDC and CMS guidance is that testing, then serial testing, would have to continue every 3 to 7 days on all negative test results until you no longer are getting negatives, until the outbreak is stabilized. What we have seen so far in the past is when we do have an outbreak in a building, local public health has been very helpful in working with the facilities to develop that strategy for serial testing until the outbreak is stabilized. And we can help with that too if there are any questions.
Will surveyors be asking for documentation surrounding staff testing, and what type of documentation will they be looking for?
So again, they won't necessarily be coming in and looking at documentation for staff testing regularly or frequently, but they may as a part of our regular routine survey activity. And what will need to be provided is reasonable attestation that staff are being tested according to the appropriate frequency and using appropriate labs and having appropriate results. So again, if you've got electronic records or if there are paper test results, we don't have any specifications about what exactly our surveyors will want to see. But whatever records and documentation you have that you are testing according to the frequency that you are required, that will need to be available for surveyors if they are asked.
Okay. And is there a reasonable time frame that will be allowed to make sure we are in compliance with the testing requirement?
I'm just going to stay unmuted. Yeah, the testing requirements are going into effect November 1st, I believe is the date. And, it is in rule, it is a requirement. There could possibly be regulatory follow-up if testing rules are not being followed. We do expect facilities to be developing plans and in compliance with that rule upon its effective date. Now, as in all things, what we really are looking for is due diligence. If you are having any struggles or challenges at all, please contact us earlier than later, and we can make sure that you are getting up to speed on compliance, making sure that you do have the resources that you need, and we'll work with you before we get to any kind of regulatory action. But it is the expectation that within the first month of the requirement, facilities are testing according to the appropriate frequency.
And I believe we have one more. What about visitors that are visiting residents on hospice? I believe this was regarding the testing requirement.
There are not currently requirements for testing of visitors or, for example, family members who are visiting on compassionate care. Of course, full PPE must be used. Detailed plans have to be developed in your facility to provide for that safe visitation to reduce the risk of exposure. At this point, there's not a requirement for those individuals.
Okay, and full PPE must be used, or mask or eye protection.
Full PPE must be used.
Okay, I think that's all the questions we have. Oh, there's one more. Just to clarify, are residents part of the monthly testing or just staff?
staff only for the monthly testing. For routine testing, for outbreak testing, it's everybody. For routine monthly testing, it's staff only.
Okay. Well, thank you. I'm sorry if I missed any questions, but DHS will have a FAQ document to be emailed out soon. We're also going to have a repeat webinar next Friday at 1 p.m. if you have colleagues or anyone who missed this webinar. This is also recorded. We're going to put it on our COVID page on ohca.com later today, so you'll have access to that. Thank you so much for joining us today. Again, if you have questions, please email us or attend next week's webinar. Thank you, panelists, for clarifying some guidance and helping our members. With that, have a great day, and we'll see you next week if you want to join us again.
Thank you, everybody.
Thank you. Bye-bye.